appendicular skeleton, 126 bones. The axial skeleton had how many?
126 bones.
The axial? The axial had 8. Appendicular has 126. There's 206 bones in the body. The good news is the right side is the same as the left side, so it's really not, you're not really studying 80 bones, you're studying really like 40 bones basically. So it's not so bad. And you're not just studying the name of the bone, as was asked. You need to know all the surface markings of the bones. It's important because these are landmarks for very specific things. One thing is, as we're going to go into the next topic, it will be muscles. So when you're learning the muscles, some of this stuff helps you for muscles, believe it or not. So as we're going to look at the upper extremity today, and we will look at the muscles of the rotator cuff a little bit. We'll start introducing those muscles of the rotator cuff. Where exactly do they insert to? And what are they? And what is a rotator cuff? And you're not going to be asked questions on the rotator cuff on Tuesday, but it helps you to understand these locations better as I teach it, and when you do the muscles next time, it's that easier. So let's just say, let me ask you guys a question. What are the rotator cuff muscles? Can you name them? Now listen, you know, I don't expect you all to know it right away, but when you come out of anatomy, if someone was to ask you what the rotator cuff muscles, it would be pretty embarrassing if you didn't know it, wouldn't it? So you should at least know some basic stuff. So the rotator cuff muscles are the muscles that help to stabilize the shoulder. There's a mnemonic. Hold on, there's a mnemonic for the rotator cuff muscles. What is it? You know?
Sits.
Sits. S-I-T-S. That's the mnemonic to remember the rotator cuff muscles.
What? Mnemonic?
Mnemonic. It's like a way of remembering it. S is for supraspinatus. I is for infraspinatus. Spinatus. Supraspinatus. Spinatus. I is for infraspinatus. T is for teres minor. And S is for subscapularis. These are the muscles that make up what's called the rotator cuff muscle. And why are they so important? Why do we always learn about that? Is because the shoulder is a unique joint. The shoulder has a very, very shallow depression for the socket of the humerus to fit into. The glenoid cavity, or the glenoid fossa, is very shallow. Can you hand me the scapula for a second? So this is a scapula, right? This would be your right and left scapula. It sits on your back like this, and then the humerus comes in and fits into the side, right? If you look at that, it's pretty flat, right? That's a pretty flat surface. It's really not deep like your hip socket. It goes right in like those dolls, you know, and have a little elastic band, snap it right into the socket. There's very little depression here, and the strength of the shoulder is not by the ligaments. The strength of the shoulder is maintained by those sits muscles, the rotator cuff muscle. Also, it balances the movement of the shoulder. The shoulder has to have a rhythm to the movement. For instance, if you're going to bring your arms up from the side, like this, see, as soon as I hit that, the scapula wants to move a little bit. So when you bring your arms up from the side, like it's making angels in the snow, at this point, the scapula is not moving yet. From this point on, the scapula should move. And that's one of the things we do in evaluating a shoulder. If someone has a problem, we look at what's called scapular rhythm. If they start to move their arm here and the scapula is already moving, that could be like a frozen shoulder syndrome. It's locked up in there. Your body's holding it tight to protect it. So the scapula is unique, and it makes up the upper the pectoral girdle. I wrote down upper girdle, upper extremity, or upper girdle. It's really called the pectoral girdle, like the pectoral fins of a fish. So your pectoral girdle is what the arms are going to attach to. The pectoral girdle includes the two scapula and the two clavicles. Okay. Okay, so the two scapula and the two clavicles. The two clavicles anteriorly articulate with the sternum at the sternoclavicular joint. And then they articulate laterally at the acromioclavicular joint. So this word acromio becomes much easier when you study the scapula first. Right? You're going to hear these terms, acromioclavicular joint. It throws you on the heels for a second. But once you know the scapula really well, it just makes sense. This is the clavicle, and this is the acromion of the scapula. And watch, I'm going to teach it to you. So the scapula sits on the back, and it's really not attached by any ligaments to your ribs, is it? It's actually attached by muscles. And the scapula can move freely along the rib cage like this. See that? Kind of glides on the rib cage. And when you reach for something with your arm straight forward, what is that called when you reach forward like that?
Protrusion.
Protraction, very close. So you're protracting like a, when I protract out my, that's protracting it, that's retracting it, right? So my scapula will protract forward and retract back. So you can bring your shoulder blade straight back, right, like when you're doing rowing, and you could protract it forward. The scapula can also move straight up and down, elevation, and it can depress straight down, and it can rotate, downward rotation and upward rotation, right? And you have muscles that are doing that. So the muscles attach at different spots on the scapula. So how do you know where the muscles are going to and from, and how do you evaluate an injury on a person unless you know those landmarks? This is why you must learn all the landmarks. One of the reasons why you must learn all the landmarks. Also, if you're a surgeon, you need to know the landmarks even more, right? So you have the scapula sitting on the back. Now, could the scapula sit this way? No, it would get stuck in the ribs, wouldn't it? Because on the back, you have this very significant thing called the spine of the scapula. You see that? So that has to be posterior, right? Then the glenoid is where the humerus is going to hook into, right? The shoulder joint. So the glenoid will always be lateral, right? Correct? Always be on the side. So it's not going to sit this way. That would be crazy, right? It's always going to sit like that. So you know that this is, which side is this now? To anatomical position. Which scapula is this? Left or right? Left. It's got to be the left one, right? Because this is always posterior, where the spine is, and this is always lateral. So this has to be the left one, right? Correct? So if I put it on the table, I'll be able to tell left or right scapula without a problem. Should not be a problem at all. Right? Okay, so now you have a medial border. This is called the medial border of the scapula. You have an inferior angle. Okay. You have the superior border, and at the superior border, you'll notice it come down as like a notch here. You can see it better from this side way. See that notch? That's called the scapular notch, or suprascapular notch. So you have a superior border with the suprascapular notch. What do you think passes through there? A nerve, the suprascapular nerve. I always like to tell stories about clinical things. I had a patient. He was a New York State bodybuilding champion. He never won all around until he worked with me. He had a damage to the suprascapular nerve. He was a bouncer, and he got cut with a bottle, and it damaged the suprascapular nerve. So he had no control, or couldn't tell where his scapula was at his double bicep pose. You know, they do the double bicep pose. So he would pose like this and never win. I went with him to the competition. I worked with him. I said, okay, you think you're here, but you're really here. And I kept putting him into position so he had like an orientation of where he was in space. I had been working with his posture for a long time. And he won for the first time. But that suprascapular nerve passes through the suprascapular notch. See, everything has a purpose. There's a reason why we name all these things, right? Okay, so now let's talk about the spine of the scapula. The textbook doesn't identify it, but I want you to identify it. I want you to know it. The older textbooks did. This is the medial border, right? And this is the beginning of the spine of the scapula. See that? So at the beginning of the spine of the scapula, it's called the root of the spine. That's called the root of the spine. That makes sense, right?
Well, where are you pointing up, sir?
Yeah, right where the
Okay,
spine.
so right when it starts coming off the...
Yeah, just focus on what I'm doing here. Look, this is the spine of the scapula. Where it begins would be like the root of the spine, right? It's going to grow out of that. That's all. It's very common sense. So this is the root of the spine. If you have your lab book, you can mark it in your lab book today before you leave, right? Because your lab book doesn't identify. So I want you to do that in your lab book so you identify it. So when you study for the test, it says, it didn't say it in the lab book. I'm telling you, this is the root of the spine, right? And why do I do that? There's a reason, there's a method behind my minutes, not to be a pain in the butt, to help you to understand things clearer, right? It helps you to learn better. So the root of the spine, if I was to walk along the root of the spine towards the end of the spine, right, I come to a very significant location. It almost looks like a diving board, right? So I'm going to walk along the spine, make my way to the end, and what am I on? This is the acromion process. Boinga, boinga, boinga. The acromion process, right? Like a diving board. Right? So that's how you always know how to find your acromion process. If you're trying to determine where is acromion process and where you're at, go to the root of the spine, take a walk to the end of the root, and you're on the acromion process. You got it? Now, this is a great landmark because just above the spine of the scapula is a fossa. See this like little fossa here? That's called the supraspinous fossa. Make sense? Supraspinous fossa. And then below it, what do you think we call that? The infraspinous fossa. Isn't that nice? Okay, so this is like a main thing to remember. The root of the spine, acromion, supraspinous fossa, infraspinous fossa. Guess what? We learned some of the muscles of the rotator cuff muscles. Which two muscles do you think sit in any of these fossas that we just learned? The supraspinatus is in the supraspinous fossa, and the infraspinatus is in the infraspinous fossa. Isn't that nice? So it's not as hard as you think it is. Once you learn the basics, it all falls together. Then you have another process coming around the front here. You can see it a little bit here on this one, sticking out the front. But notice, that's coming off of this, right? It's not coming off the spine, right? So the one coming off the spine is the what? That's the acromion. The one coming off this glenoid cavity, or glenoid fossa, glenoid cavity, coming off is the coracoid process. Coracoid. The reason why I emphasize coid, because there is another landmark later on that sounds like it, but it's not the same. This is the coracoid process. Coracoid process. And that's an important landmark. I treat it almost every day. Patients with pectoralis minor syndrome, your pec minor attaches there. The pectoralis minor, which would actually rotate the scapula forward. Right? Also another muscle, the coracobrachialis attaches there. So these are all specific locations. There's nothing that's here that doesn't need to be learned. Let's put it this way. Everything needs to be learned. Okay? And it's nice because, you know, it doesn't change. The human body won't change, and you won't have a new model to learn. Once you learn this model, you learned it, right? And you learned it for life, and that's good. So here's your glenoid cavity, okay? And if you went at 12 o'clock on this clock, make it like a clock, and you went at exactly 12 o'clock, there's a little tiny tubercle. And if your book doesn't identify it, I want you to identify it. That's called the supraglenoid tubercle. Does your book identify it?
No.
Are you sure?
It just labels as glenoid cavity.
Are you sure?
It just says
Yeah.
glenoid cavity.
Yeah, it should mark it. So at the very top, I want you to mark that. That is the supraglenoid tubercle, right at the very
Sorry.
top. It looks like a little lip coming off it almost, right? If you imagine it's 12 o'clock on the clock, at the very top is the supraglenoid tubercle.
So it joins the cavity with the,
Supraglenoid tubercle is at the top of the glenoid cavity. And that's for an insertion of the long head of the biceps. That provides an insertion point for the long head of the bicep. And this will be significant when you do your muscle test, when we do the muscle exam. When we learn about the muscles, this point is significant to you. Okay?
Insertion point for the what?
Insertion point for the long head of the bicep. And down at the bottom, does it identify it? Yes. It identifies the infraglenoid tubercle. You see that? Coming down at the bottom at 6 o'clock. And the infraglenoid tubercle is an insertion point for the long head of the triceps. Infraglenoid tubercle is the insertion point for the long head of the tricep. And this is your glenoid cavity, coracoid process, acromial process. This is a good image to try and study it from this angle. It helps you learn a lot. This is your lateral border, medial border, superior border with the